Meeting to the computer.
Recording in progress.
There you go.
All right, good.
Yeah, thank you so much. Okay. All right. Well, good afternoon, everyone, and thanks for joining us for our afternoon session. We have two groups presenting, and I'm sure you're going to enjoy them thoroughly. My name is Carrie. I'm on the planning committee for the Health Equity Summit, and glad to see so many faces. Hope you all enjoyed your lunch. So just a few reminders are that we will be holding questions at the end of each presentation, and in order for folks to hear on Zoom, we'll be bringing around a microphone. So please raise your hand when you have a question, and we will bring you a microphone so that you can ask it. And if you're online, you are able to turn on your closed caption if that is needed. And right now, I will turn it over to the Home Health and Hospice team to get us started. The first presentation is Innovative Approaches to Supporting Independent Living, Vermont's Longitudinal Care Program for Adults with Complex Needs.
Welcome all. Thank you so much for coming to see what we have to do. I am so excited to tell you all about this fantastic program that we're trying to really roll out through our Home Health and Hospice. We're part of our network. Home Health and Hospice has joined the network a few years ago. And so our official title is UVM Health Network Home Health and Hospice. And then we get to add on yet another word, Longitudinal Care Program. So on the screen are all of the people that have contributed to our longitudinal care program. Christine Warnicki, April Plant, Debbie Tate is a nurse that works with me. There's Chantal Peters, who's a community health worker who works with me. Claire Loop is a social worker who works with me. My name is Joseph Haller. We also have Allison Burlock, who helps us with our analytics. And then here we have Jamie McKenzie and Maddie Ruth. Jamie is a nurse with our remote patient monitoring portion, and Maddie Ruth is our community health worker lead. Get these slides moving. Let's see how that, so the clicker stopped, so we'll just do that stopped too. Of course. There we go. All right, so I just wanted to give us the whole agenda here. We're going to do an overview. We'll talk about our model, the goals that are driving our model, who our team is, talk about our clients, some outcomes, reflections, and some contact information, and finally a question and answer. So this is our longitudinal care program. It's a long-term support and care management for complex, high-risk patients when they're no longer eligible for an insurance-provided home health care. Typically, insurance will allow home health to do some work for clients on a short-term basis based on their acuity. And then once they've reached a baseline, then they're asked to be discharged from our agency. And this is a program set up to support those folks who may no longer qualify for home health at home. Our goals are to improve the patient experience and outcomes while also decreasing costs and utilization of acute health services. So this is kind of where we're trying to capture. The top is the traditional model of some of the folks that we've recognized who really could benefit from a program of support between episodes. We see that they might be incorporated into a hospital setting, then they might move on to a rehab setting. That's not necessarily always the trajectory, but then they get a home health referral for a skilled episode at home health. Typically, after they've gotten to a baseline, we would discharge the person, and then they would move on through life with the new skills that they've learned through home health and by that touch point with the health system. But however, there are those folks who kind of fall into this gap because they can't keep the knowledge that they've learned, or because they have so many complex needs that they keep falling into the cycle of home health episode, discharge, hospitalization, home health episode, discharge, hospitalization, all the way through the continuum of their life until it's an end of life. What we're trying to do is break up that gap, support those folks who typically go through the cycle over and over by supporting them once they've been discharged from an insurance paid for home health episode. So again, our goal is to improve the care for high-risk patients, actively engage patients to reach and maintain their health goals through ongoing interactions. That would be our strategy to try to get these folks really incorporated with their own self-care. Our actions would include routine wellness nurse visits, ongoing health education. The nurse may also do some med reconciliation and support, routine community health worker visits, access to a medical social worker, care coordination, access to on-call phone support, and an option for this ongoing or initiation of a remote patient monitoring system. The typical patients that we find who fall into that gap have two different conditional categories that they fall into. They have multiple chronic conditions, congestive heart failure, diabetes, COPD, chronic kidney disease, and an anxiety or depression component. But they also have these several social determinants of health disparities that we've recognized will have them fall right back into that gap. Could be housing insecurity, food insecurity, transportation issues, low health literacy, English as an additional language, and few or no supports at home. So our team, you see me on the far right. Then we have Debbie Tate, who is a community health, our LPN 2-3, who's a complex care nurse. Then there's Chantal. She's a community health worker. Claire is our social worker. And then Maddie Ruth here is our community health worker lead. Who you don't see is Jamie McKenzie, who is our remote patient monitoring nurse. And she kind of does two things. She works for our program, but she also works for the insurance-based home health episodes. So as a nurse, this is my role. So my role would be to try to help somebody set their goals, usually around a health-centered goal. I provide advocacy. I support with their education. I support them with their disease management. I interpret medical terms and concepts. I would also assess for any chronic disease progression and alert the appropriate person at the right time if something starts to change. Our medical social worker role provides consultation for available community resources, acts as a resource for understanding insurance structures, assists with identification of a plan of action for reducing or controlling psychosocial factors that would be barriers to their treatment. We have the community health center, community health worker.
Thanks, Joe. So a little context, folks might get to see Joe once a month. Our clients might get to see our social worker once a month or every other week. And then I get to fill in between. So we have this consistency of touch points of actual in-person meeting, which we find really valuable. So my community health worker role, we're really establishing and building trusted relationships. These are relationships that we are exemplifying when we're also meeting our clients at their doctor's appointments. We're building trust not just with us, with their entire care team. We're connecting patients, clients to their health and social services. So all of our community partners provide access to culturally and linguistically appropriate health education and information. That is a mouthful. We would not be using all those words. Build individual capacity through goal setting, action planning, and really having it being whole person centered. We're coming with what knowledge we have, but this work is really being led by the clients we get to work with. the rest of the list we can go through, identifying and connecting patients with community resources, review social drivers of health, demonstrate and act patient advocate and liaison, and practice curiosity and asking questions. Really the basics of whatever big words we bring to the table and our expertise, we're constantly learning from our clients that we get to work with to understand why they are where they are, why they are who they are. And that really helps us figure out how to support them and what their goals are. And Jamie, I'll pass it to you.
Thank you, Maddie. So like Joe already mentioned, the remote patient monitoring aspect bridges in within both of the programs our skilled insurance-based home health care and longitudinal care program. And oftentimes we are identifying that patients could benefit from being enrolled in the longitudinal care program while they are on a skilled episode of care. So what is remote patient monitoring? Remote patient monitoring is a program that monitors vital signs on a daily basis and also asks daily health survey questions to patients on a daily basis through a touchscreen tablet that transmits the results and the answers to those questions wirelessly for a nurse to review. And you can see in the photo here there, that's an example of the equipment the patient is using. And so at that point, the nurse can review the information and can contact the patient if the results are abnormal or the answers to the questions are concerning for early symptoms of worsening health status, and try to figure out if it's just a need for some reinforced education about their health, disease management, or if it requires escalating the issue for follow-up from their care team, including their providers, whether it's the primary care physician or a specialty provider. And so we hope we think that the daily monitoring does improve disease management by allowing providers to respond to changes early and prevent, hopefully, emergency room visits and or unplanned hospitalizations. So the benefits of remote patient monitoring include monitoring patients between their home visits. And once they are discharged from the home health services and onto longitudinal care, that the frequency of those home visits does lessen to less frequent. So this is important that the monitoring continues on a daily basis through this remote monitoring. It helps patients to develop a daily routine for health management. It reinforces education on health management. It helps to trend data for field clinicians and the providers as needed, promotes greater patient engagement, and results in high patient satisfaction, and hopefully helps to reduce ED and hospitalization.
I think the best way to kind of describe how this program works is to give you a real life example. You're going to meet Denitsa. She's a 70-year-old female, obviously, and she is a immigrant to the United States. She was in the Serbian and Bosnian wars. Her family moved here to Vermont. And in about 2015, she discovered that she had undiagnosed and untreated diabetes that led her right to the hospital system. And over for the last, probably from 2015 until 2021, she'd been at the hospital 8 times and had multiple episodes falling through that gap 8 times with multiple infections to her toes because of her untreated diabetes. She was referred to us through our skilled episode team, recognizing that this person may need support because she just keeps cycling through that episode of hospitalization, home health, hospitalization, home health. What we found was that she has very few supports at home that are capable of helping her manage her disease processes. So she came over to the United States with her family. She has 2 adult sons and 1 adult daughter. The adult daughter moved to Ohio. Her 2 sons still live in Vermont. One of them really struggles with cognitive disability, so he is unable to be a care provider. She has another son who unfortunately has been struggling with addiction issues. And she also has a husband who has really struggled with his own alcohol addiction. The story is similar to many of what we've all experienced within our own lives, but she also had the addition of the trauma of being a refugee, and she does not speak English at all. She is a Serbian speaker only. So instructions from the hospital, instructions from our specialists, instructions from the home health agency could not continue because they were usually typically in English. So what we did was we immediately got our longitudinal care program started for her once we got the referral. She had a remote patient monitoring system that we continued along, but we incorporated the community health worker. That community health worker, Maddie, was able to discern all of the barriers to her health. Maddie, do you want to take it from there and talk to us about what you discovered?
Yeah, thanks, Joe. So I want to draw attention to, they may not be moving because there are only so many of us in the room, but there are some binders that we brought. I realize folks who are not in the physical room won't be able to see them, but we'll figure out a way to share the contents after this. But when I get to show up, or Chantal or other community health worker, we show up with a bit of paperwork to keep us organized, especially noting that it's paperwork in English. Just want to shout out, there's been a lot of amazing translation improvement that's happened within the network. And so that as well, just last week, I got something translated for Denitsa, which was very exciting and could not have happened before. So celebration for that. So when I get invited to meet one of our clients, I get to ask all the questions of who they are, what's important. Got to join this morning a session, a reminder of why it's important to do the work we do. Learn more about them beyond their health. A lot of times they're in a room where their health is the center of what's being discussed. And so we get to include that piece, but really get to learn who they are and figure out what supports they actually need, want, and what we know our community can offer, and then be creative beyond that. So for Denitsa, it includes, we're fortunate to be able to have access to interpreters. So that's why if you're able to see the picture there, I'm holding a cell phone, which is so important. It's the only way I can communicate with Denitsa. Is through our interpreter service, which I have learned folks do not always have access to outside of a health appointment. So when Denitsa wants to make a phone call to set up transportation to a doctor's appointment, there is not always an interpreter available. All of these pieces, figuring out what the barriers are, what support I can provide, and ideally how to connect Denitsa to that support. Me being the bridge, not always the actual support. There is so much to talk about with Denitsa. I realize we only have so much time, but I think it's the reminder of any person we get to work with or be a support person with, whatever role we're in. I think it's a reminder to keep asking questions and remembering that the work is never done. I'm still learning things about Denise. These trusted relationships, we know as individuals, they take time. They take the practice of showing up again and again. And we're fortunate that we get to do that in this program.
So I just want to reiterate what Maddie just touched on. This is a relationship building program. This is somebody we're intending to support through the rest of her life. and hopefully have her have a soft landing when it is the time for her to leave this realm. Since we've gotten incorporated with her, our visits have shifted a little bit from disease management, which has been really difficult at the beginning, to some health management discussions. But now she has the freedom and the relationship to talk to us about her real goals. And that is, as a grandmother, she has two very sweet children who live in Ohio, and she just cannot wait to show each of us. She insists that we come to see her that week when she has new photos. And she has a video of one of the children that she wants us to watch nearly every time we're with her, because she's so proud to be a grandmother, and she can shed that patient role for at least a moment because we've built that relationship with her. So the impacts of the program. So obviously, we've created a relationship with Denitsa, and this is one of the impacts we create with all of the patients. They learn to trust us, ask us questions. We get curious and ask them questions. We help them coordinate care among all of their providers. Their providers reach back to us when they're finding a barrier to communication with that patient. We assist with preparing and attending physician visits in person. So if somebody really struggles to learn while they're at the physician or struggles to impart what they want the physician to know, we can be there for them during those visits. We reinforce the education that they might be receiving from the physician or a specialist that would reduce the anxiety that they might feel. We improve their ability to manage their own self-care. They have somebody they can reach out to if they have a question. They no longer just ignore a question because they don't know how to tell a provider about it or explain it, whether they speak English or have English as a second language. Oops. Yeah, back here. Oh, that went forward. There we go. So we've added a social worker to our program. Originally, it didn't have a social worker, but we realized that it was really important for us to have that community resource expert to help us navigate kind of getting all of the community resources together, whether it's a transportation issue, a housing issue, a food issue. We also have the community health worker support that, as Maddie touched on, bridges the time between nursing visits or the social worker visits. And then we also have the access to the remote patient monitoring to help with disease management support. Most of the folks that we work with who use the remote patient monitoring system love it because it helps them stay on track. They learn what their vital signs need to be specifically for them, whether they fit within a category or not. They see a change that they recognize and they'll reach out to us. So this is what patients have told us.
So if it wasn't for LCP, Longitudinal Care Program, I just didn't have enough strength and wherewithal to do it on my own.
They kept me out of the hospital.
It makes me want to track my vital signs. It gives me a better idea of when I need to call the doctor.
I would not have made it to my appointment on my own.
Make this program permanent. Oh, did something wrong. So what is next? So this is a grant-funded program. So we are supported by an accountable care organization that we belong to called OneCare. And we're looking for more support within the community so that we can expand our program to more people within our community. We were awarded a grant from the community-based service grant that was an ARPA grant that our state received. We're going to use our program analysis that's built in with this grant process to create an analysis to prove our worth and look for an expansion. We also want to expand our existing LCP program and develop new ones within the state to support folks. And we also want to really incorporate ourselves within our community so that it's not just a referral process within house, a case manager who's about to discharge from a skilled episode, but perhaps we could get buy-in and also get direct referrals from something like the RAP program at the hospital or from a physician's office who's recognizing that somebody who may be falling into the gap before they get hospitalized. We're really looking to build out this program to support all Vermonters. And part of our program is going to see how that happens in 2025 and beyond. So these are our contact information. I'm just going to read mine out for those who may not be able to see the screen. My email address is my name, Joe, joe.haller@uvmhomehealth.org. My phone number, 802-734-4632.
And if anyone is in need of more information about our remote patient monitoring program, my email is similar to Joe's, except with my name, JAIMIE.McKenzie, McKenzie @uvmhomehealth.org. Phone number 802-922-6481.
Thanks. And final contact information is for myself, Maddie Ruth. Email is Maddie, MADDIE .RUTH@uvmhomehealth.org. Phone number 802-598-9152. Remembering the importance of speaking slowly. It's one thing I've learned, one of many things I've learned from our program is take your time.
So we have about 5 minutes left for some questions, some answers. Yeah, go ahead. So that is a barrier that we would like to come up with. So the question was asking, how does somebody make a referral? This person's in a community-based setting and wants to make a referral to our program. Our program has been basically working on referrals from in-house only, those case managers within home health and hospice who've recognized somebody who would need our support gives us the referral. However, we are hoping that if we can do an expansion, that we will take direct referrals. There is sort of a workaround, and that would be to have a referral that might qualify for somebody for a regular skilled episode that is paid for by insurance. And then I would take that name that's provided to me and poke at the case manager and say, this person might benefit from the longitudinal program. So you're welcome to reach out to me with a name, and then we can see if they've already been in our system or will be about to be in our system. Go ahead.
I'm just curious how expansive the program is before the expansion. Like, is this only really serving people in the local Burlington or like Chittenden County area, or how far into Vermont are you?
That's a really great question. The question was about how expansive are we within the state and specifically within our region here in Burlington. Our program had begun with just about 27 folks. With our expansion, we're trying to get up to 40 folks within our program by the end of this year. There are 2 other agencies within the state who also have a very small program, one in Central Vermont and one in the upper Connecticut River Valley, Caledonia County. And so they have an even smaller census, but we're really trying to expand this for the rest of the Vermonters. Yeah, so Maddie reminded me I should remind everyone that our territory is within Chittenden and Grand Isle counties.
Hi, I'm a social worker at Champlain Valley Physician Hospital, and I'm just wondering if there have been any discussions about the LCP program with the New York partners within the network.
So the question was, are there any other programs that might be in the New York region across the lake as part of our network? And yes, we have actually done a presentation to the CVPH about that. And so we're hoping that this is something, a model that we can expand across the lake.
In that question, though, we are learning we all have to be self-advocates and advocates for each other. So we always appreciate learning who our allies are and speaking with you. So we're always happy to keep having those discussions. So thank you for asking.
You can tell that Maddie makes a fantastic community health worker.
Communication style. And I have a kind of two-pronged question, and it's about the folks that you've involved so far. And that is, has there been a case where you guys have identified someone who you think would really benefit, but they disagree? Their interest is not so much in that kind of program. And then the second one is anybody with cognitive or communication impairments. So somebody with intellectual disability or developmental disabilities.
So the question was about, have we ever had any referrals for folks who may or may not, who may not be really vested in this program? And then the second part of the question was, are there folks who may have some communication barriers or cognitive deficits that we may need to address? And yes, we have had referrals from folks who may have just been off of an episode and they're really ready to throw that remote patient monitoring system out the window. They're tired of seeing a nurse come by. They really want to be a person and not a patient. The beautiful thing is once we start incorporating and talking to them about how we advocate for what their goals are, not our goals, we almost always get buy-in and we remain friends and supports for the rest of their lives. As for folks who may have other barriers, we really struggle to have a referral based on what you're discussing with communication barriers, but we do find that we are becoming fast experts and learners about communicating with people who may not have the same skills or a different set of skills than we're understanding when we first get to know them. So using translator services, using cartography to communicate, understanding that perhaps the reason that they've been disengaged is because they are hard of hearing, or they really struggle with understanding even some of the terms that have been thrown around, and to save face, they pretend they understand. So we've learned really quite quickly, once we build those relationships, how to really kind of right the ship on the communication.
I noticed on your list of like what qualifies somebody for the program, I'm curious, one, was it those specific medical conditions, diabetes, congestive heart failure, or is that just a sampling? And also, does substance use disorder or people who are engaged in substance use on the right hand category? Do you take folks who struggle with substance use? That's a huge part of the people that I work with, like a barrier to them addressing health concerns. So curious your approach.
Sure.
And you use harm reduction in that approach.
Okay. So the question is a really great question as well. The question was about what are the qualifications? We built the program based on some chronic disease management that the skilled episode side has been seeing over and over. So those were the listed ones, the diabetes, COPD, congestive heart failure. That's the type of patient who typically benefits the most from what we originally intended for the program, and that is disease management, chronic disease management. And then we've learned that through that, the right side of the screen, where it showed the social determinants of health, really were drivers for quite a bit of the lack of communication, the lack of connection with managing their disease process. We are just learning how to incorporate substance use disorder, basically by fire, somebody who may be using, and we're just discovering at the time. So it's something that we have yet to learn and will be learning, and would love some support on how to learn how to do that.
We have time for one more question.
My comment is a comment and a question all at once. First of all, endorsement for this program. I just got to say, as a person in the community who is a heavy referrer to the program, you have no idea how impactful the program has been for the specific population that they serve. It's very difficult to serve the individuals in a supportive way, and they align and they combine forces and really help make a difference in all of our community and our circle of care. So kudos to the longitudinal care program. And my question, because I have to have a question if I'm holding this thing, is how can we, as people who have now been excited by your presentation, how can we help in making more access with the LCP program for furthering your message to the world?
That is an excellent question about how you could help maybe create a process for our program to expand. And that is to reach out to those folks who are in your leadership. And we have a great advocate within our own agency, our president, Christine Warnicki, who has really taken this under her wing as a project that she sees is something that would benefit all of Vermonters. Population health is her bailiwick. And luckily, we fall underneath that with Christine's wonderful assistance. So bringing it to your leaders that this is a program that you've interacted with or sounds like a program that really is something that all of our community should have access to.
Thank you so much, Joe, Jamie, and Maddie. Those wonderful and beautiful comments to close us out for our first part of our session.
Thank you, Rob.
Right. And now we have Alexis with childhood adversity, social determinants of health, and mental health equity.
Thank you. Hi, everyone. I'm really excited to be here. Going to do a big shift in gears from what we've been talking about, but I hope that you can still find pieces of this that are relevant for your work in the populations that you serve. So just for some context, I am an assistant professor in the Department of Psychological Science, at the University of Vermont. So this is my second year here at UVM. I direct the Family, Environment, Resilience, and Neurodevelopment Lab, or the FERN Lab, and my background is in developmental psychology. I'm broadly really interested in how issues of childhood adversity and social determinants of health are affecting brain development and mental health for children and adolescents. So today I'll be talking about one piece of that, looking at specifically at these different experiences of adversity, social determinants of health, and its impact on specifically mental health equity. So the slides are not moving. Oh, you try on the corner. Cool. Are we in this one? I think so.
No. Okay. There are two separate ones, right? Sorry. Oh, what is that? There. Let me just be slow. It's good to see. No, because well, this is fast. Okay. Oh, good job. I might need to. I don't know how to do this. How to do the stop share, reshare.
Thank you. Awesome. Back on track. So, perfect. I want to start today by just giving you sort of some background on my program of research, why I study what I study, and then I'll share one particular project that we've been working on that gets at some of these issues related to child mental health equity. So for some background, there are a couple of critical things that motivate my program of research. The first is that we know that more than half of individuals in the United States experience at least one adverse event prior to age 18. Here I define adversity pretty broadly, so this could include experiences such as child abuse, neglect, parental separation, poverty, parent substance use, and so on. And this is important because we know that up to 50% of youth develop a mental health disorder following adversity. And adversity exposure is the strongest risk factor for the onset of mental illness. So this prevalence of adversity exposure combined with the really profound consequences that it has for youth mental health means that it's really important for us, I think, to be conducting research to try and better understand these processes and reduce the prevalence of youth mental health disorders. And there's really robust empirical evidence for this link between adversity and child psychopathology. There's been many, many studies done. Some of you might be familiar with the original Felitti et al. ACEs study from the 1990s, which really spurred a lot of research and public health interest in this issue. So we have plenty of evidence showing this basic association, but it's really complicated. So adversity is often associated with higher levels of mental health problems for youth, but that looks really different across individuals. So, for example, some children might show more internalizing symptoms following adversity, so things like anxiety or depression, whereas others might demonstrate more externalizing type symptoms, so things like rule-breaking behaviors or substance use or attention problems. So there's a lot of heterogeneity in the specific ways that adversity kind of manifests for youth. And at the same time, it's really important for us to acknowledge that not all youth who experience adversity or trauma are going to have any sort of mental health consequences at all. There's really a profound amount of resilience that we observe in youth. But all this variability means that it's important for us to kind of better understand why this is happening and for who. And so these are some of the key questions that I ask in my research lab and that my research team works on. So why is adversity associated with mental health outcomes at all? What are some of these underlying mechanisms that might be linking these experiences with later mental health presentations? Who is most likely to experience negative effects? Again, this looks really different for everyone. What might make one child more vulnerable to the effects of adversity relative to another child? What are some of the protective factors that might be at play and promote resilience for some children relative to others? And finally, under what conditions are we seeing adversity really impacting mental health for children? So are there certain environmental contexts where the association between adversity and mental health might be strengthened, or other places where it might be weakened? Again, thinking about some of those protective factors. So this is some of what I'll be talking about today, thinking about under what conditions and for who specifically we're seeing the impact of adversity and different types of adversity. A lot of the variability that we see in these outcomes is really driven by inequities, systemic level inequities. So we know that children and families from disadvantaged and minoritized backgrounds are systematically exposed to greater harm and adversity. We can think about of many different drivers of this association. So things like socioeconomic status, family's income or access to education, ability, race and ethnicity, place, so the geographic area where a child is growing up or their neighborhood, and so on. This is obviously not an exhaustive list, but these are just some that I wanted to highlight, and more are illustrated here in this nice model. So this is illustrating the bioecological systems model, which is really popular in developmental psychology and helps us think about an individual child's development as being nested within multiple levels of a system. So we can think about really proximal levels of a child's environment, so the family, their peers, their teachers, and then we can zoom all the way out to more macro system level factors. So maybe the political context that they're in, the public policies that are affecting them and have downstream consequences for their well-being. For the specific research project that I'm going to be talking about today, I'm going to be especially focusing on issues of socioeconomic status and geographic area. So here I was specifically interested in understanding a few different things. So first, how do adverse experiences and socioeconomic disadvantage both contribute to youth mental health outcomes? Do they have differential associations? And how are they contributing to different types of symptom presentations? So again, we might see more anxiety symptoms, or we might see more externalizing symptoms, and do these contribute in different ways? What factors might buffer against these risks? So there's been a lot of research trying to understand, what might serve as a protective factor for kids who are growing up in stressful contexts. A lot of the prior work that I've done has really focused on the parent-child relationship. We know that a positive, warm, supportive parent-child relationship can be really protective for kids in these stressful contexts. But for this particular project, I was interested in kind of moving beyond the family context and thinking about broader social support networks that can support kids and maybe serve as a protective factor in these stressful contexts. So here I'm going to be specifically talking about community cohesion, which is the idea of trust and unity and support within a community or a neighborhood, and how that might be protective for kids. And then finally, I wanted to ask how these processes might vary depending on the geographic contexts where youth live. So overwhelmingly, the research that's been done on this topic, at least in psychology and neuroscience, has been done with youth in urban or suburban areas. But those findings might not generalize to all different contexts. And so thinking about how this might look different and how these risk and protective factors might vary depending on where specifically a child is growing up. And so here we'll be specifically comparing rural versus urban contexts. So I want to tell you a little bit about the study that I've used to dig into some of these questions. This is a study called the Adolescent Brain Cognitive Development Study, or the ABCD study. And so this is a longitudinal study of youth development that includes 21 different study sites across the United States. You'll notice that we have a study site here at the University of Vermont, out of the Department of Psychiatry. It's headed by Lexi Potter and Hugh Garavan. And so they've been heading the data collection effort for the Vermont site. But there's 20 other sites that are also collecting data. So we have really rich geographic variation and a lot of variation in kids' experiences. So kids started this study when they were 9 or 10 years old. There's nearly 12,000 families enrolled in this study across the country. And they come in once each year to do a variety of different things in the lab. So they're doing a lot of questionnaires on things like their home environment, their school environment, their peer relationships, their mental health. Their parents are providing information on a lot of these factors as well. They're also doing MRI and neuroimaging, which is another piece of my research that I won't be talking about today, so that we can understand some of the neurobiological mechanisms that are at play. So this is a really, really rich data set with a lot of participants that we can use to tap into some of these questions. I'll also just note this is a publicly available data set, so anyone who might be interested in these sorts of questions or in research broadly with youth, if you do the data use agreement, you can get access to these data, and I'm happy to talk with anyone more if that might be of interest. So, like I said, there's nearly 12,000 youth in this study. They were 9 or 10 years old when they started the project at baseline. And then for the analyses that I'm going to be showing you, those go through the 3-year follow-up period. So again, there's going to be up to 10 years of data. This is just kind of the first chunk of that. So they're 12 to 13 at the final time point that I'll be talking about here. The sample isn't perfectly representative of the national population in terms of like race and ethnicity, but there is still good variability, which you can kind of see the breakdown here. And then median income is relatively high, so between 75,000 and 100,000. Just quickly describe some of the measures that we use to get at these different constructs. So a lot of this is self-report, where kids are filling out questionnaires or their parents are filling out questionnaires to tell us a little bit more about their experiences and the environments that they're growing up in. So for adversity exposure, we have a measure called the negative life events scale. So kids fill out this checklist and indicate how many different of these negative life events they've experienced. Those could be things like exposure to violence, having a death in the family, or losing a friend. There's a variety of different stressful events that they can indicate whether or not they've experienced. And so that's lifetime exposure to these different events up through this first time point when they're 9 or 10 years old. And then we're separating that out from socioeconomic disadvantage. These are closely intertwined issues, but they are distinct constructs. And so I wanted to look at them sort of separately. A lot of the times we'll look at socioeconomic disadvantage at the family level. So how much income is a family making relative to the number of people in their home. But I'm also interested in getting at a more structural level, sort of beyond the family context. And so we can do that by looking at neighborhood level disadvantage. So one of the great things about this data set is all of the data are geocoded based on US Census data. And so we can get things like this area deprivation index, which tells us the degree of economic disadvantage that the community is facing where this child lives. Community cohesion is another questionnaire where they're reporting on things like how much they feel supported in their community, do people look out for each other, things like that. Mental health symptoms are assessed with this pretty standard child behavior checklist. So parents are reporting on the degree of symptoms that they're seeing in their child. And here, again, we're looking at those different domains of symptomatology. So we can think about internalizing and externalizing symptoms. Okay, and then finally, since those data are geocoded, we can also look at things like the rurality and urbanicity of the areas that kids are growing up in. Again, this is based on US Census data. Overwhelmingly, the sample is in urban or suburban areas, but there is a proportion of the sample, about 10%, that is categorized as rural. So this offers a really unique opportunity to kind of dig into some of the variation that we might see across these different contexts. And let's start just by talking about some of the descriptive differences that we see between youth growing up in rural versus urban areas. So these are the mean values for each of the variables and the standard deviations, but I'll just highlight some of the key differences here. So looking at neighborhood disadvantage, we see that there's a significant difference such that kids in rural communities are experiencing higher levels of neighborhood disadvantage relative to kids in urban areas. But at the same time, kids in rural areas are reporting higher levels of community cohesion relative to kids in urban areas. And this is broadly consistent with what we see about some of the challenges that come with living in rural areas, but also some of the real strengths. And then for negative life events, we see that actually the kids in urban contexts are reporting slightly higher levels of exposure to adversity or negative life events. And interestingly, there's no sort of baseline differences in terms of internalizing and externalizing symptomatology. They seem to be experiencing relatively similar degrees of mental health symptoms. Okay, but to better understand, whether or not community cohesion is protective, how these different sources of stress might actually be predicting later mental health outcomes, we tested a more formal statistical model. So this is a structural equation model, basically just allows us to do a series of regressions and statistical tests to see whether these things are significantly associated with each other. So I'm going to walk through this step by step, starting with the effects of socioeconomic disadvantage. So looking at its effects on both internalizing and externalizing symptoms. And the same thing with adversity exposure, its effects on each of those outcomes. And then we can look at interactions with community cohesion. So does community cohesion kind of modulate this association, for example, between economic disadvantage and externalizing symptoms? And so our hypothesis here is that it would moderate and it would be a protective factor in that, for example, maybe kids with higher socioeconomic disadvantage would show higher externalizing symptoms unless they had really high levels of community cohesion. That would be protective. Okay, so moving into the results, again, we'll kind of go through this step by step. So starting with the effects of socioeconomic disadvantage, what we found was that higher disadvantage was associated with higher externalizing symptoms. And again, remember, we're comparing these models across rural and urban youth. So running all of these twice just to see the difference in any effects. And so this is true for both rural and urban youth, that socioeconomic disadvantage might be a risk factor for some of these externalizing symptoms. And that's things like substance use or conduct problems. Although I will note that this effect was significantly stronger for rural youth. So it seems to be even more pronounced for kids growing up in rural contexts. Turning to the effects of adversity exposure, we see that higher adversity was associated with higher both internalizing and externalizing symptoms. But in this case, that was only true for urban youth. And so this might be tied to the fact that these kids are from baseline reporting higher degrees of adversity exposure in the first place. And so maybe that has a more pronounced effect on their symptomatology relative to kids in rural areas. But then getting to our kind of key question here, is community cohesion actually protective? So we see some evidence for these risk factors that in certain contexts for certain kids, economic disadvantage and adversity exposure might increase risk for mental health problems. But can community cohesion kind of offset some of those risks? And broadly, the evidence is telling us yes, but it depends on certain factors. So we see this interaction between community cohesion and socioeconomic disadvantage on externalizing symptoms. So what that means is that higher disadvantage was associated with higher externalizing symptoms, except when community cohesion was high. And so there seems to be this protective or buffering effect. When community cohesion is really high, this link between economic disadvantage and externalizing symptoms disappears. So this is true for urban youth. We see that statistically significant effect. For rural youth, we're seeing a similar pattern of effects where this does seem to be significant interactions, predicting externalizing symptoms, but that significance is more on the cusp of what we would consider to be statistically significant at p.52. And so I'm a little careful about how much to interpret these findings. And I think in the future, I'm really interested in doing replication studies and collecting more data with rural youth that we can really use to test the robustness of these effects in rural communities. Okay, so to quickly summarize everything, I really think that delineating how these different types of adverse experiences and disadvantage can shape development. And this is important so that we can identify potential targets for intervention and prevention efforts and ultimately mitigating some disparities that we observe in youth mental health. Again, this research has overwhelmingly been conducted with youth in urban or suburban areas, and so there's, at least in psychology, so there's really a need for us to expand and try and better understand how this might be similar or different across these different geographic contexts. And we did indeed see some evidence of that here. So again, for rural youth, we see that higher economic disadvantage and higher community cohesion are at play. So again, kind of balancing these potential risk and protective factors. And for urban youth, we see a higher degree of adversity exposure there. So there's some of these baseline differences between groups. And then we do see some evidence that community cohesion is a significant protective factor, especially for youth who are experiencing socioeconomic disadvantage in urban areas. And again, I think we're going to require some future research to really ascertain the robustness of this association among rural youth. So ultimately, I think that reducing these systemic inequities that are tied to youth's places of residence, so things like neighborhood disadvantage, should be the key focus for policymakers and practitioners when we're thinking about prevention of mental health problems. And at the same time, for youth who are already experiencing this disadvantage and are living in these contexts, community cohesion might be one sort of way to offset risk for externalizing symptoms. And there are some interventions that have been conducted that have tried to actually increase community cohesion in different contexts that have demonstrated some preliminary effectiveness. So this might just be one additional tool for supporting resilience and reducing youth mental health problems. Okay, so I've only talked about a very small piece of the puzzle here. There are a lot of really complicated factors that play into youth mental health. So we can think about some of those more proximal relationships, family relationships, peer relationships, school contexts, other more macro level stressors, things like climate change and racism, discrimination, and so on. How can we possibly account for all of that? And while we don't, in this particular study, we haven't, that's one of the goals of the ongoing study that we have here at University of Vermont. So my lab is currently collecting data for a research study that we're calling Conversations About Resilience and Early Life Stress, or the CARES study. And so right now we're doing focus groups with teens across the state of Vermont online to try and better understand sort of their perceptions and lived experiences of a lot of things that are causing stress and adversity. So asking what's most salient for them, what things do they perceive to be protective in their environment, what sorts of relationships do they have that are either positive or negative for them, and what are some other stressors that we might not have been thinking about. And so this is really in the interest of making sure that we're centering their experiences in our future research and incorporating measures that are really targeting issues that teens are most concerned about. We're also asking about things like representation in research. And so one of the challenges with some of the work that we do is it often requires people to come physically into the lab and to travel to Burlington, for example, to participate in studies. And especially in rural contexts, there can be a lot of barriers in place. So we're talking a lot with kids about different barriers that they might see in being able to participate in these types of studies and thinking about what we can do on our end to help minimize some of those barriers. So this is also my shameless plug that we are currently recruiting for this study. We're looking for teens aged 13 to 18 to participate. It's a 1-hour online study. Again, we're trying to get representation from across the state. Teens get $25 if they participate. So if you know a teen or work in a clinic with teens and want to spread the word, that would be so great. So we can really hear from a wide range of different voices. Okay, well, yes, maybe. I think I broke it. Oh, here we go. Maybe. Just a recap. Whoops. I'm so sorry. Okay, well, I can maybe take some questions while I'm getting this fixed. I just won't click so fast this time. The last slide, I just wanted to acknowledge my awesome team who has been working on collecting some of these data with the focus groups and some of the outreach work that we've been doing to talk to families about neuroscience and psychology. If you're interested in these topics too, please feel free to contact me. My information's up there. You can also find us on Instagram. All right. Thank you.
Does anyone have any questions they would like to ask?
Thanks for your work. Just a question. I'm curious what an intervention to increase community cohesion would be. Like, what does that look like?
Yeah, that's a great question. So this is not work that I've directly done, but some of the things I've seen is having like researchers or practitioners form like community groups and gatherings, and just creating sort of the infrastructure for communities to come together and create social ties and build those. I don't have a good example of like what that specifically looks like, but yeah, basically just creating those opportunities for communities to come together and get to know each other and build that social cohesion and trust and unity. Yeah.
Hello. Oh, there we go. Okay. Um, Two questions. One on I have a similar question on community cohesion. Is that a binary variable or is it continuous so that it's got a strength to it?
Great question. It does have a strength to it. So it's rated on a scale, I want to say from 1 to 3 of like, yes, very, no, not at all, or and then in the middle. So yeah, it's a continuous variable. So we can kind of look at that.
Excellent. And then the other question I have is, did you look at for adolescents and I know you looked at urban and rural. Did you do any comparisons by gender?
Oh, good question. I did not formally do any comparisons by gender. I didn't mention that I did, control for the effects of gender and age variability. So those are accounted for in the model, but I didn't specifically look at, how that might vary. But I think that would be interesting because we definitely, especially in terms of like symptoms, see some gender differences that might be playing into this. Yeah, good question.
I'm just curious, have you thought about in the context or from the lens looking at community cohesion as since it's more prevalent in rural communities, is there a way to determine that that's truly a protective factor and not maybe like what we're interpreting as community cohesion is more a place of like being less willing to externalizing symptoms or things like that, like maybe lower self-reports as opposed to actually having that protective factor?
Oh, I see what you're saying. I mean, so I think that might be the underlying mechanism is that kids are being observed maybe by people in their community. They feel like they have people watching what they're doing, looking out for them, and maybe discouraging them from engaging in maladaptive behaviors. And so that might be why exactly that is a protective factor. But it's possible that that might be impacting the way that kids are responding to. Is that what you're getting at? Like maybe their parents are reporting lower levels of symptoms or behaviors. Yeah. Yeah, of course.
So you mentioned that you bring these individuals into a lab and engage with them to run all these tests. Is there, how do you evaluate the impact of putting them in an isolated environment and forcing them to remember everything that they went through throughout the year on a single setting to report out versus finding a way to document actually what happens in real time and then seeing the continuity or lack of continuity of certain experiences?
Yeah, this is a great question. And there are certainly limitations to asking people to come into the lab and to sit in this sort of sterile environment that is not very natural and answer all these questions. And it can be very, cognitively demanding and time consuming and tiring. And so those are definitely things that we consider as we're deciding which measures to implement. How can we minimize the burden on participants when they come in? To your point, there are a lot of novel methods that we can implement to try and get more at this real time rather than this retrospective, like how was I feeling the past 6 months? Like, what are my symptoms like? Or things like cohesion. All this is kind of thinking about the recent past. There are different methods that other people have implemented to try and get at this real-time piece. So using smartphone apps, and it'll ping participants every now and then to say, how are you feeling right now? Or have you engaged any of this behavior today? Or have you been feeling this way today? Things like that kind of give us more detailed timestamps on when and how these things are happening. I haven't personally implemented that, but I think, there are challenges and benefits with that too. Benefits, you get this real-time approach. some challenges and like you don't really know what they're doing or who's filling out. You don't have any control over like who's actually filling out the survey. They could be handing their phone off to a friend, and so the data can get a little messy. But there are certainly ways around that and strategies to work with that. So yeah, both good approaches.
Question. Thank you for the presentation. I'm reminded I have so much to learn about research in general, so thank you. Curious about the rural and urban, just to understand, in some studies, data collection that occurs, Vermont as an entire is considered rural, and just hoping if you could elaborate on what that looks like in your research.
Yeah.
I have a totally different question then, but I'm going to let you
Okay.
for that one.
Yeah, great. So this is based on US Census definitions of what a rural urban area is, and it's based on census tracts, which I think are smaller, smaller than individual states and usually at smaller levels. And so in this case, I think it's any census tract that has like less than 2,500 people is rural. And so by this definition, not all of Vermont would be considered rural. So yeah.
Thank you for reminding me this is census related. Only other question, I get really intrigued by research that happens at a young age because I get to work with folks at an older age.
Mm-hmm.
And am intrigued to understand. I really just learned about ACEs last year through a presentation.
Okay.
And am, at that point was like, oh, how do I work with my clients who now have a primary care doctor they feel connected with, yet have really never been experienced any sort of official evaluation, et cetera, et cetera. And just wondering if you have any insight to share about supporting folks beyond this study who are in the community and maybe connected, maybe part of community cohesion groups. But I think for figuring out how I can support them with either similar realization, moments of reflection, just would appreciate any of your thoughts on that.
Yeah, that's a great point. And I think most of the research that's been done in this space has been focused on child and adolescent effects. But there's increasingly, folks looking at how this is affecting people even further down the line. Like these really intense and severe childhood experiences can impact people into their late adult lives. And so it's important to think about that when we're thinking about the different experiences that they're bringing to their healthcare sort of contexts. And so I think just part of it is just increasing awareness. Like people are talking about ACEs more, which is good. Talking about adversity and the effects of trauma. And I think that's definitely a generational thing too. Like the older clients that you work with probably haven't had as many conversations about this or about like trauma-informed care and things like that. And in part of that is because, this initial study was only done in the 90s, but really started to bring attention to these issues and incorporate them into both practice and research. So I think just being aware that those are experiences that your clients might be bringing with them, and thinking about how some of their behaviors or the thoughts that they're sharing might be tied to some of those experiences, and if it makes sense or if that fits within your role to give them space to talk about that, and also providing supports and services and directing them to places where they can get sort of psychological support to work through some of those challenges. Yeah.
We have time for one more question, if there is one. Thank you so much, Alexis.
Thank you all.
Okay, and the audio's on. Yep, there you go. Let's bring your PowerPoint back up. So it's there. We're on one. Is it?
Yeah. Well, it did here.
It's not changing there. So. Now. It's this one. There you go. Okay. There you go. Do you want the wireless mic? Do you want to walk or what's the vibe here?
We'll have it available in case somebody
Yep.
feels like.
So these are on. You just got to turn this up. Yep. Just flick that up. This one is on as well. Same thing if you need it. Right.
To this, it's also that. Okay. We're gonna figure it out. But remember, this is the video for the people online. So, yeah. Conversation. Yes. Good angle. You can. Yeah. So you can hit next. And also your blended there notes, they're down here. And that's the words the next there. But our clicker works. This clicker, that's one. Okay. Backward. Okay. Oh. Still assistant. That's
Okay, hello everyone. My name is Shauna. I am on the planning committee all the way from New York. Today, you are here for human trafficking team and staff development for the response to survivors across the North Country. Reminder to all of you, lean into the mic. We'll have questions at the end. I'll let them introduce themselves. Who is going first?
Hi there. My name is M. Doyle. I work in the emergency department at CVPH in Plattsburgh, part of UVM Health Network. And I'm here part of the team.
Hi, I'm Gail Bajelko, also from CVPH in Plattsburgh. I am the Director of Quality and Safety for the Emergency Department.
Hey, everybody. Erin Stewart, Chief of Psychology at CVPH. And Shauna said questions and answers at the end, but actually, this topic is best trained if you interrupt us and ask your questions when they come up. I don't know how Gail and Em are going to feel. You have a question already, Carrie? Oh. Okay. Okay, Carrie will run a mic to you, or I'll repeat your question. So first of all, this is really exciting that we're here with all of you. This is a labor of love for us at CVPH and in the North Country, but it's also a requirement. So we'll talk more about what that means. So you'll see us sort of interchanging what we say. This is a team-based effort. It is the only way to combat human trafficking is on a multidisciplinary team. You actually can't do it by discipline or alone. So we're here as a team, and the team is bigger at CVPH, but we hope that you'll walk away with a definition of trafficking, but I'll just put out a disclaimer that even if we give you a definition, it won't be what you see. So we can define it for you by statute and by law, but it's actually not what you're going to be standing in front of or working on. So we'll define it for you. You will have a beginning understanding of the barriers to the services in the North Country and how to navigate and what we've done thus far. But also, you won't have any understanding to the barriers because every trafficking case has barriers that you can't possibly imagine that you're going to run into. So we'll try our best. You will have a list of resources and understand how to report. That is a defining thing that you will walk away with because some of this is absolutely mandated reporting and some of it is not. And the only way to actually support a survivor of trafficking is to hand them off to resources. So we'll talk more about that. And you will, but safely, hand them off safely to resources. You will understand the importance of both a trauma-informed and multidisciplinary response. I'll just tell you from doing these cases and serving women and children for a very long time. If you're not trauma informed, you lose them and they run away and walk away. And so we have to be on our best trauma informed game because they are the best detectives that you will ever stand in front of or interview. And they know when you're not telling the truth and they know when you're not being trauma informed. And usually what you'll get back is a whole lot of cuss words and then them walking away from you. So we are on our best game with trauma-informed content warning. Some of this is really hard. And very often when we talk about human trafficking, somebody says, I can't believe this is actually happening and it's this bad. So content warning is if you need to take care of yourself, please do that in whatever way that means. Ask questions, share your thoughts. We're open to everything. We're learning with you. I have not ever worked a trafficking case that I didn't learn something from, and it is all hard. So the ideals of diversity, equity, and inclusion are critical and rampant within all scenarios and dialogue of human trafficking. We applied to talk about this because if you ever wanted to work on diversity, equity, and inclusion in the hardest possible way, it would be on victims and survivors of human trafficking. And we'll try to talk about why that is, but there is no profile. But as a world and as a society, we believe there is a profile for survivors and we believe there is a profile for perpetrators. And that brings with it a whole bunch of diversity, equity, and inclusion issues that we're going to try to talk about. We're not going to watch a video.
Right. We can't get the link to work. But if anybody's interested in this slide deck, it will work within whatever system you have. So at the end, our information will be up so you can email me. And I'm M. Doyle again. I'm happy to send that off to you.
And basically the reason why a video is sometimes important is because this concept is sometimes so outside the box for people in privilege and people in healthcare, and specifically people in Vermont. I have run into so many conversations in Vermont that people just can't believe that trafficking exists. And so the videos sometimes land it for you. I'm happy to do that in a different way by talking about what we're actually seeing and what the cases actually look like. But we're going to be careful and conscious not to give any identifying information or demographics now that we're seeing a whole bunch more cases in the North Country. Some of them are profile and high profile, and some of them are public. Do you need us, Kara? No. Okay. Yeah, we're good. Thank you. So we can talk about case specific as long as it's a composite and a compiling so that they're not identifiable. And that will do the same thing as a video. But if you have time afterwards, doing a YouTube search on videos of what trafficking is and listening to survivors talk about how it happened to them and how they got out is extremely meaningful. The federal definition of human trafficking is the exploitation of a person for labor or commercial sex through force, fraud, or coercion that is above the age of 18, because force, fraud, or coercion doesn't have to be present under the age of 18. So that becomes incredibly important because under the age of 18, any exchange of something of value for labor or sex acts is trafficking by statute. Anything of value to the youth under the age of 18. So that means that nobody has to threaten them. Nobody has to lie to them. Nobody has to coerce them by false promises. It's just the act of exchanging a vape, couch surfing, a roof, material possessions, Michael Kors, whatever it is of value to that youth, is that exchange for sex or sex acts or labor is by definition human trafficking. In adults, there has to be force, fraud, or coercion in order for it to meet the statute. It doesn't mean that it's not happening if they don't say there's no force, fraud, or coercion, because sometimes those leverage points of force, fraud, or coercion are so subtle and under the table that that's not what they lead with. They believe they're consenting to the experience, and so they don't lead with force, fraud, or coercion sometimes in adults. So we still serve them because that is still their experience, but they may not have access to criminal charges. And as a side note, these cases are nearly impossible to prosecute. And so in healthcare, I don't care about a prosecution. I don't care about law enforcement involvement, although Em and Gail will tell you that if a survivor wants to work with law enforcement, I will bring them. But that is not my end goal, is because they are extremely hard to prosecute. And actually, what is a survivor's recovery path is figuring out how they want their life to be. And a lot of them do not want to work with law enforcement or prosecutor's office for a lot of different reasons, which we can talk about later. So sex trafficking, there's two pieces of human trafficking under the federal statute, sex and labor. And I'll say the Vermont landscape, we got to work diligently in 2014 and 15 on sex trafficking. And we did not start working on labor trafficking until 2018, 2019, when we got some grant funding. And in New York, you can maybe talk more about that, but we want to be thinking about what both of these are and looking for both of them. And actually, in the cases that we're working right now, there are components of both in some of the cases. So drug muling along with exchange for sex or sex acts, they're both labor and sex trafficking. This is where we realize why New York region does not have a choice in what we do in terms of human trafficking in the health network. We are required by New York State regs to screen and identify and intervene in every patient that we see in every hospital in New York. That is not the case in Vermont. In Vermont, you don't have regs that you have to screen and identify every patient, but you are mandated under the age of 18 and elder and vulnerable. So we can talk more about that, but Em put this link in for you so that you can see on your own time what the regs are that we're required to meet the standard for. And so later in the talk, we'll talk a little bit about what we've done to come into compliance with these regulations. We've lifted a ton in the last year at CVPH and in the New York region, but we have a ton more to do for the identification and assessment of all patients that come in for care. What are we seeing? A lot. We are seeing a lot of post-pandemic sexual exploitation, labor exploitation, domestic violence, and substance use, and they all have to do with one another. So we're seeing an uptick in the cases, and I think that's two reasons why. I think, first of all, I think there's more cases, and two, I think we're getting better at identifying them and gathering the numbers. So Vermont had a similar experience in 2017 and 18 when we weren't gathering numbers. We weren't seeing a lot of cases. And when we started gathering numbers, we were seeing much more cases. And so we are seeing a lot. And now at this point, it's 1 or 2 cases per week in the hospital. And when we first started this, it was 1 or 2 cases every 3 or 4 or 5 months. So if you just think about those numbers, that is an incredible uptick. And what we're seeing is an index of substance use and trafficking and an index of social determinants of health, so homelessness and poverty in trafficking. And we're also seeing in the kid realm, in the minor realm, the index of exchange online for vapes and drugs and love and belonging through platforms, mostly Snapchat in New York. So was there other things?
No, that was it on the time.
What were the other two? Oh, why do we see it in healthcare? Oh, yeah, go ahead. I'm happy to hear it. What do you have?
Are you feeling like that's like socioeconomic, like there was a reduction in jobs post-pandemic? Like what's the correlation to post-pandemic and seeing it?
It would be a guess on my part. But if I watch the trends, so human trafficking is up 150% post-pandemic. The numbers are national. I think in the recent cases, in the minor cases, in the youth cases, there were long stretches of periods of time where youth were online without supervision. And they were online without supervision because parents and guardians believed that they were doing schoolwork. And they were required to do their schoolwork online. And so one of the major risk factors for human trafficking is a lack of supervision and also the amount of time that a youth or a minor is spending online. And so I think that's part of it. I think also people were in their homes, struggling hard, isolated, resources depleted, people coming into homes, checking on kids and adults decreased. DCF and CPS involvement didn't stop, but was less in home and less eyes on in what's going on and less school-based service, less mental health-based service. All of those are preventative factors for the index of trafficking, which is the need for love and belonging. And so what I think happened is that everybody started to suffer, and perpetrators of trafficking, and I use that word loosely because there is no profile, but perpetrators of trafficking, all they need to do is find a vulnerability or a void to fill. All they have to do is look for the loophole, and they just have to plug it. And so when you look for a void or a vulnerability and you have the means to plug it, it's very hard for somebody who's suffering to not get moved into that, because they at the same time use a lot of threats and coercion. And so it would be a guess, but it's national trending up, and most certainly national trending up in areas that are struggling with substance use and that are on a corridor of travel. And Emma's going to talk about where Vermont and New York sit and why we're a corridor and what risk factors that has. But I think we need to first, in order to combat it, we first have to acknowledge that it's happening, and it's happening in increased severity and acuity and also in quantity. And that's the only way to get in front of it, is to think about the fact that there's a ton of survivors and victims right now that nobody has any idea what they're involved in. And I just did a talk last week, I think, with the FBI in Plattsburgh to talk about sexual exploitation online. And it was really sad. It was for parents, and they are all struggling with how to get in front of a train that has already left the station. Yeah. Retta.
Am I on now? The lady that just asked the question around the increase. So since COVID, there's also been a increase in really pushing assessment and identification. do you think that that is also part of being able to support survivors, and that increase in uptick is that we're also required to assess, and we're not just poo-pooing it away saying, oh, well, this is, just this thing that's happening on the side. We're taking it seriously and we're saying, hey, like this is important.
Yeah, so that's a really good point, because this human trafficking experience of response it's the if you build it, they will come sort of thing. So I think there's an uptick nationally in the experience, but there is an uptick at CVPH because we're paying attention to it and we've had financial backing and we've built a process. And I'm very, very proud. The cases are extremely difficult and challenging, and they take a toll on everybody that works them and on our organization. But I'm extremely proud that we have bigger numbers now, because it was always coming in. They were always coming in, and we were just not seeing them and noticing them and doing anything about it, which is directly related to the next question, is why do we see it in healthcare? So 83% of survivors that are involved in being trafficked meet with a medical professional during their trafficking experience, 83%. And less than 10% of medical professionals are trained. So if you think about those numbers, they're all coming into our clinics and our hospitals, and it's the end stop on whatever it is that is their ailment. And in a darker sense, a trafficker or person labeled as a trafficker wants their commodity, their business, to be in functioning form. And so they will drop their survivors off at hospitals and clinics to get care because they need them to be in functioning form. And that's a much darker conversation, but it is part of the reason why they're coming into medical professionals, but they're not coming into DSS, or they're not coming into other kind of service, is because a trafficker needs to keep them well enough. And very often that looks like the trafficker trying to stay with them or be with them or supervise it. But it is a intersection of medical professionals with survivors of trafficking. And if I forget to say it later, somebody can ask me, but there are indicators of what we see when someone is coming into healthcare that don't look like trafficking, but are actually the indicators that we should dig a little bit deeper on what the medical ailments are. What was the last one, Em? Why? Oh, why are we seeing an increase? We talked about that. You queued me up. Thank you. Yes. So you're looking for unwanted pregnancies, STDs, unexplained injuries. Overdoses is one that we are really unfortunately seeing. A lot of our cases recently have come in by overdose or for a mental health evaluation. And I was telling Gail that in every other arena that I've ever worked in the country on trafficking, they were never coming in for mental health evaluations, and they were never hospitalized psychiatrically because they very rarely get suicidal or homicidal. But in the North Country, because of our pickup order, which is a very low threshold for a police officer to bring somebody in for a mental health evaluation, we have a very low bar for people being brought in for acting a certain way. And so we are getting a plethora of women and children coming in on a pickup order for a mental health evaluation when it's actually an experience of sexual exploitation or labor exploitation. That's a little bit different here in Vermont, because a pickup order is very hard to do in Vermont, but not very hard to do in New York. And that's a much longer conversation. There's people in the audience that are experts on that. Happy to have that conversation, but you're looking for an unexplained story. You're looking for obsession with a cell phone. You're looking for weird visitation experience, and you're looking for a presentation that is very difficult to manage. So they're my favorite kind of patients, and they are not always everybody's favorite kind of patient. So you're looking for somebody who is petrified beyond what they can possibly manage in any other way except for anger. And so they're riled up. They're
causing a ruckus.
They're causing a ruckus. There's always a disturbance. They are hard to interview, and
they want to get out of there.
They want out, and they want out fast, and they want their cell phones. And so you're looking for both a medical experience that doesn't make a lot of sense, and you're also looking for a behavioral experience that you can't really pin something that makes sense on why this person would be so petrified that they actually are combative and aggressive and volatile and all of the things. Does that help? Yeah. Okay.
I have a quick question.
Yeah.
How often are the traffickers actually coming into the ER with them?
So interesting in New York.
Yeah. And then how often are what are the profiles like? Are they going like on immigrants or low socioeconomic, or you're probably getting into that?
Yeah, so we'll do the profiles in a bit, but if you want to talk about the who are the people, how are they coming in? Sometimes it's a drop off. Sometimes it is the trafficker or the perpetrator bringing the person in and really wanting to be present for all things and answer all the questions. So when you're in interviewing a patient, whether you're a nurse or a different kind of provider, you know, your spidey sense is always up for all sorts of different things. And the biggest thing you have to do in any type of healthcare when you walk into a room is put all your bias aside. We're going to talk about trauma-informed care and why, and Aaron mentioned it, why that's so essential, but it's essential in every single room, but it is especially essential in these rooms. So when you go into these rooms, if you're seeing somebody who has a substance use disorder and they have skin lesions because they've been popping and they just want to get their oral antibiotic and go back out, you know, hey, I see you're not, I don't see a home address here. How are you paying for drugs these days? Right? There's a way that they're getting the drugs, right? And if the person is not there and there's a way to ask them safely, there are ways to get in and get that information. You have to remember when you ask a question, it's the answer that you don't always see, and that's the one that you want. So you have to hear beyond the thing that the person is saying. How are they saying it? Are they looking at you in the eye? Are they just trying to get out the door?
I have been shocked at CVPH of how little we have their trafficker or perpetrator wanting to be with them. It happens more on the Vermont side. There was a much bigger conversation with the ER on the Vermont side, but we have a lot of women who are saying their traffickers are right outside. So they don't come into the facility in New York as much as they do in Vermont. I don't know what that means, but they do very often wait outside the facility, rehabs, hospitals, clinics, for them to be done with whatever it is. But we'll talk more about that, Dana. Yes.
Sorry, so in Vermont, so in our Epic, and you folks may have the patient FYI, the flat. Okay, so it's just and Brandon can probably speak to this being in the ED. We have a lot of patients, and I can think of a few that I've interacted with. I'm also in patient advocacy here at UVM, and you see the patient FYI, and you see the history of violence, and you saying that, I'm like, wait, are we doing? I don't know if we're doing enough here. I'm also not just in the ED; we cover the whole hospital. But just I from the Vermont side, we don't. And you see those flags, and you see the other socioeconomic issues, and meeting with the ED every week. I don't know, but this is
so more to come. I want to say that when I have believed that a survivor of trafficking is violent and entered a room in that manner, I have never been successful. So when I interact with a survivor of trafficking, I sit right next to them after I ask permission, I spend a lot of time close in proximity. I do not want to give them the sense that I believe that they're violent, because the protective instinct is so much that they do not want to be touched. And so I'm trying to be trauma informed, but I'm also trying not to suspect that somebody who is combative or aggressive and under so much pressure can't accept empathy and love and regard, because actually they're sponges. And so there's much more to say about that. I think it's a really important conversation, and I would like to have a network-wide response. I'll leave it there. So, 83% experience poverty, 96% experience abuse, and that's during trafficking, and also a risk factor for entering into trafficking is a trauma history. 93% experience substance use and mental health challenges. And this number is, in my estimation, even bigger in Vermont and New York region, is that we're seeing most cases have a substance use component, especially in the adults, and also now in the minors with regard to nicotine. We talked about the New York region exacerbation, what it is, but I'll just drop this really quickly, is that there's a lot of generational mental health, generational abuse, molestation, incest, sexual assault,
and poverty.
And poverty in our area. And those are all desensitizations, traumas that make somebody not feel scared when somebody is trying to groom them in the same way that a person that doesn't have a trauma history would. So the New York region has all of the social determinants of health issues, and also we're doing something about it. So there you have it. Substance use component in the adults, we talked about that. Everything is voluntary in an adult, unless they're vulnerable or elder. Everybody you call, everybody you talk to, everything you do is voluntary in an adult patient of trafficking. Houselessness is a big deal in the North Country, and it's an index for the leverage point of force, fraud, or coercion. And social determinants of health, which we just talked about. In minors in the North Country, we're seeing an online component. I would say probably in the last many cases, 95% of them have an online component. Everything is reportable in a minor case. That's a mandated report every single time across the country. And runaway status or lack of supervision and supports, which I tagged at the beginning of this, are a major, major problem, because the trafficker is looking for somebody that nobody's looking for, nobody's watching, because they need a period of time in order to groom them, in order to bring them in. Mandated reporting in New York, CPS investigates it. CPS does not investigate out-of-home perpetrators. They go to law enforcement in Vermont. I think it's one of 3 states in the country that investigates in out-of-home perpetrators. So DCF in Vermont investigates human trafficking in minors. The regs are that we're required in New York to screen and intervene in all patients. The regs in Vermont are that we're required to screen and intervene in, not required to screen and intervene in adult non-vulnerable patients, but are required to screen all children and vulnerable adults. Em's going to talk about community resources. I'll just say that we did a bunch of work in Vermont in 2017 and 18 when we got our federal grant. And when the federal grant left Vermont, we went back into silos in human trafficking in Vermont. And now in New York, we're trying to be a hub at CVPH. And we'll talk more about why that is important, and that there's not a lot of services around the hospital. What have we done so far? We built a policy and defined practice. We've educated our staff, although we have a ton more education to do. We've walked side by side with those frontline bedside folks that are identifying, and it's not just the nurses. We've gotten referrals from security officers. We've gotten referrals from techs, sitters, leaders, managers, all of the things. We've been clear about what we can and cannot do. And when I say we can't do, what we cannot do is report any adult that doesn't want services or reported. made our patient survivors human by focusing on patient care. We've talked a lot about the fact that these are people and that all of us could be involved in trafficking if we had had a different story, family of origin, experience, lack of supervision. They are all humans and they are the most resilient humans. And when you pour into them, they give a ton back. And so we try to make them as human as possible. We've infiltrated the community to become a hub. We've spent a lot of money. Thank you to CVPH Foundation. They have supported us every single year. We've shared our stories of hope amongst the hospital when we have been able to intervene with somebody and somebody has chosen to save their own life. We have shared those stories in the way that we can. We've recognized our staff that is doing the work because it's extremely hard work. And we've been bringing administration along on a case-by-case notification basis, meaning we have a very large notification chain when there's a trafficking case, and we bring the leaders along by educating as we go through the case. I'm just whispered Gail's turn. Before Gail starts, I just wanted to say one thing, which is that Gail, I think, could have chosen for this not to matter. It takes a really special ER leader for it to matter the most about these cases because they take a lot of money and time and energy and they're sometimes combative. And Gail made this matter at CVPH, and all of the cases that we saw initially were in the ER. And so I just wanted to say thank you for doing that. Do you want to talk into that one?
Yes. So, in addition to being a new position of Director of Quality and Safety for the Emergency Department at CVPH, I have been a nurse in the emergency department for almost 40 years. So a big share of that, I've been a sexual assault nurse examiner and have had, excuse me, exposure to some of these patients. So being a forensic examiner or a sexual assault nurse is not only about evidence collection. There are times where we may not collect any evidence, but our role in that multidisciplinary team is integral to the care of that patient. But when we are involved in the forensic exam, there are really things that we want the patient to drive and things that we expect the patient to be involved in. We can't force the patient, as Dr. Stewart alluded to. Everything that we do for them has to be voluntary. But in a forensic exam or a sexual assault exam, we get consent from the patient for a lot of different things. So we will talk to them about consent for treatment. We will talk to them about consent for evidence collection. We will talk to them about consent for post-exposure prophylaxis or pregnancy prevention. So we really go through each step of the process and give them a little bit of control back by asking them for consent. And I always start the exam by saying, you know, this is about you and this is about what you want as a survivor. So we don't force anything at all on the patient. So part of the history for these patients is also very important. It may be difficult for them to remember because a lot of patients that are trafficked, it happens over time. And if any of you are sexual assault nurses in here, you probably have protocols that speak specifically to time frames. Like if the assault happened in the previous 96 hours, we will do X, Y, and Z. That may be very difficult for a survivor to talk about or to delineate that time. So you may have to use a little bit of judgment to determine how best to serve that patient. And being a forensic examiner is not just about the evidence collection. So we're also involved in education and prevention and training for these survivors. So it really is a lot of different things that we can provide for them. The physical exam is also something that's very important. Again, the patient has to consent to that. A lot of times they are thinking about what's the next step. So if I consent to the physical exam, what are you going to do with that? What do we do after that? Like, who are you going to tell? Who are you going to show? What are you going to do? So they have a lot of questions, and it's important that we listen to their questions, try and alleviate their fears early on in the process as quickly as we can. Yes, she has a question.
Can you speak to the consent process for minors who have screened positive? And I think I'm thinking of consent for the physical exam, history collection. So both ways, consent from minor patients and speaking to families or parents, and then maybe consent from parents to perform the physical exam.
So I think it's probably a little bit different for survivors of trafficking than it is for sexual assault. And I'll speak to the sexual assault piece, and then I'll let somebody else speak to the trafficking. So we can take consent from a minor over the age of 12 on their own who presents saying that they were sexually assaulted and want an exam. That being said, there are a lot of cases where parents find out that the child may have had intercourse. They bring the child in demanding that that child have an exam. That is not something we are going to force on that child. The child has to agree to have that done. And if you think about physically, like how could you do an exam on somebody who doesn't want it done? It just can't be done. So that child has the right to determine their own consent. And I'll let somebody speak to the trafficking piece.
What I'll say about that is we have to think about who are the perpetrators. So if it is a familial perpetrator, then we need, somebody who actually has guardianship of that patient, and that would ultimately be CPS in the immediate moment.
Does that answer your question?
And also they can refuse. So similarly to what Gail just said, the only piece of trafficking that is mandated is our report to DCF or CPS. The rest of it, the patient determines their course of treatment. I have had several conversations with kids about what might be in their best interest and laying out what the options are, and done that with the guardians when the kids want me to. But all we can do is provide information, and we can't force anybody to do and participate in any of that. And that's across the board.
Did that answer your question? Okay. So also with the physical exam, we have to keep in mind that these patients are afraid and they're scared and they want to leave and they're worried that maybe their trafficker is outside. So I've seen cases that aren't even trafficking cases where the patient is like, I need to stop and go outside. I have to go see somebody. So I'll ask them, do you want me to come with you? Is it okay that I come with you? I'm happy to support you and be with you. Sometimes I do, sometimes they don't. But it's really listening to them and trying to build that relationship, which is really something that the sexual assault nurse examiner builds with that patient. As far as diagnostics, again, they can consent to have blood drawn. They can consent to evidence collection, and they can consent to whatever part of the evidence collection they want or not consent to what they don't want. I'll usually explain to the victim that, what we collect for evidence is based on what they say happened to them. If this happened to them over a period of time, they may not remember exactly what they did or what they said or if they scratched the person or anything like that. So we collect whatever evidence they will then allow us to collect because they're unsure. And a lot of times that's what happens. And then documenting everything that we find and everything that we've done is really important because not only might it be prosecuted as a sexual assault, but it's also important in the sex trafficking realm. There are a lot of medical consequences to human trafficking, and Dr. Stewart did touch on a bunch of these already, but they can be clumped into physical manifestations as well as psychological, and then, of course, injuries from the violence. Sexual assault nurses are specially trained to deal with victims of violence and trauma. So they're looking for things that the average provider or nurse might not look for. So physical manifestations, for example, like Dr. Stewart mentioned, you may see multiple pregnancies, or you might see STIs, HIV, wound infections. You may see poor dentition, and that might be what they presented with. So they might come in and say, you know, my teeth really hurt, and you look and, you know, they don't have hardly any teeth. That's your opportunity to ask questions. When did you last see a dentist? Do you have dental insurance? Do you go every 6 months? Do you go every year? And then listen to their answers, because it's important to inform us what we need to do. They might have scarring from prior assaults, and that's something, you know, that the sexual assault nurse is trained to look for. One thing that we also look for, which is a little bit different on trafficking victims, but we do a head-to-toe assessment on this patient, looking at every part of their head down to their toe. So we get to see all of their tattoos, we get to see all their piercings. So being astute to what they actually have tattooed on them. Do they have a tattoo that says daddy? Or do they have a tattoo that says for sale? Or, you know, anything like that, that again will inform us that this might be a victim of trafficking. Things like malnutrition, not caring for their diabetes, those are all medical, physical manifestations that can lead us to ask a lot of different questions. I think I skipped where I didn't want to skip. So going back. All right. So psychological trauma. So a lot of things with the psychological trauma is part of their presentation. So as Dr. Stewart talked about, sometimes they'll come in and it seems like, you know, they're a mental health patient, like they are totally unwrapped. Like you have no idea what they're talking about, what they're saying. They might be super paranoid. And we have a tendency as medical professionals to label that person, right? This is a mental health patient or a patient with a behavioral health problem. Maybe they have PTSD, maybe they have substance use disorder, maybe they're suicidal or homicidal, but that may be a psychological manifestation of their trafficking and not necessarily what their primary complaint would be. And then, of course, we have injuries from the violence. So again, sexual assault nurse examiners or forensic examiners are specially trained to look at those injuries, either from the sexual assault, or they might have orthopedic injuries, they might have musculoskeletal injuries, they might have, you know, little areas that they've been picking at that are infected, like Emily mentioned. So really it's keeping an eye out for those things specific to their medical care. And then the SANE nurse or forensic examiner are really an integral part of that multidisciplinary team. So we can't do it alone, but what we can do is holistically look at the patient. So sometimes you have the ER doctor who's just looking at the emergency medical condition, whether it's their substance use or whether it's their mental health issues, or maybe they're dehydrated, or maybe it's poor dentition. They're looking at just those specific things. But the sexual assault nurse has the opportunity in the 3 or 4 or plus hours that we're alone with them to look at them in entirety. So we have that ability to build trust with the patient or with the survivor and develop that rapport that sometimes the other providers don't have the opportunity to do. So an ER doctor isn't going to spend 4 hours with the patient. Doesn't matter what's wrong with them. You know, they don't have that time and they don't have that ability. And that's about it for me. Does anybody have any questions specific to that?
All right, so we're going to talk a little bit about multidisciplinary team building. You've heard up to this point all the different components that are involved in some of these cases. So I'm sure you can imagine the breadth of the response that's necessary to help. Sorry, excuse me for a second as That is why. These patients are complex. The situations they're in are very complex, and we need all different types of brains and people assisting us to help move them through to places of safety. Who is involved is going to be anyone who you can think of: social work, security, bedside clinicians, docs, nurses, and techs, county health officials, Homeland Security, your administrator on call if they need to access greater funds or additional people at the bedside or in the team room to be able to assist, legal, and psychiatry. How do you get people involved in these teams? You ask. This is a passion for a lot of people, right? If you say, "Hey, who's involved in being in human trafficking assistance?" you will get a lot of respondents, and that's sort of how we began a year ago. We offered up a human trafficking 101, and there were a lot of people who came, and a lot of people who afterward put their name on a list because they wanted to be involved in the team once we got it going. There it is. Okay. I think I skipped one, but so trauma-informed care. This, of course, I think there it is. Sorry, thank you. It's a service delivery approach focused on understanding and responding to the impact of trauma in others. So Gail and Dr. Seward both spoke about the implications of somebody showing up to your emergency department or any of your facilities with this trauma in active form, right? So as a person going to assist that person at the bedside, you need to understand, how do I do that? How do I ask the questions? How do I not make them mad and throw all the F-bombs and throw me out of the room and fire me as part of their care team? If what I want to do is help the person, then I have to approach it differently. You also spoke about when you go into those rooms where you have the FYI, the history of violence flag on, right? It's a notification to the care team that this is a room I need to be careful in, but it's not just about care of yourself, it's about care of that person. Right? They responded in a physically aggressive way for a reason. So when you go in there and they're here with, skin lesion or because they were on a pickup order, how you ask the question, like we talked about before, matters. That you ask the question matters, and how you present yourself in that matters. So trauma-informed care also encourages an understanding everybody has trauma. Right? When we don't know what that is. And if you expect that the room you go into, that person sitting in that bed has some history of trauma, whatever it might be, means that you may ask that question differently, and that will matter. These are some core principles of trauma-informed care. So of course, it is not just about safety of the person, it's safety of ourselves. So making sure that we have those history of violence flags, so we don't just go busting into a room saying, "What can I get you to drink?" Right? We think about how we do that, and we help our care staff to be able to do that differently. We want trustworthiness between all the people, and that happens through making sure that you are thoughtful when you're having interactions with your patients and your staff members. We do not want to re-traumatize. Right? That is one of the number one goals of trauma-informed care. If we ask the question the right way, or if we have the intention of doing that and make the effort to do that, then we can show the person who's sitting in the chair in the bed that our goal is not hurting, our goal is helping. We want to promote positive outcomes by emphasizing the physical, psychological, and emotional safety, like Gail had shared. We want to talk about empowerment, which is important in all forms in healthcare for children and for adults. But we show empowerment by asking, what do you need? Hey, you're here for all these other things, but what do you need right now? Do you need something to eat? Can I get you some extra socks? You look like you might be cold. Would you like a shower? Right? There are all sorts of different ways that we can empower people and help humanize them and remind them that we're there for them. We're not trying to get something from them. Also remember, with human trafficking, there is a big component of criminalization, right? So the language that we use in these cases, so prostitution, it's forced exploitation, forced sexual labor, right? A lot of what I call them patients, but people who come to us have a history with the law enforcement because they have been picked up or have been for sexual exploitation, okay, or for it's hard to use, they are being picked up for prostitution. It is not prostitution. They're being forced to do it, but they have a criminal record as such. So when they are with us, we have to remember it's the whole person. There is a story of why they are in that bed, and they bring a story with them. And if we go into these rooms with an idea of what it is, we lose the ability to make connection with that person and to find out what that story is and to truly help. How do we become trauma informed? We want to educate ourselves. We can take courses. There are lots and lots of free resources. At the very end of this, there's a whole list. If you give me your information, I will send it out to you. But all of the people involved in the work throughout this nation, as well as the world, offer resources for free for a reason, because we don't want there to be a paywall or a physical barrier between the people doing the work, which often are resource depleted, and the people who are going to receive that care. So tons and tons of free resources out there. Okay, I'm going to talk. Did you want to add anything about trauma informed?
No, but I just wanted to add that in most states in the country, when a person is found to be the survivor of trafficking, their criminal record that they engage with during that time can be wiped by law enforcement and prosecution. And so what Em was saying in terms of decriminalizing folks in trafficking starts in the beginning, goes through the middle, and is all the way to the end. And those are all the safe harbor laws. So we want to not be looking at them as criminals, because we understand by leverage points they are forced to engage in certain behaviors.
Okay. So I'm going to talk a bit about New York right now, because that's my specialty. It's a really big state, right? So a lot going on in this state here. There's a big yellow area. I'll talk more about that. That is the Adirondack Park. You can see I-87 all along the eastern part. There's 300 miles of I-87. See if I can get this to work. There it is. Okay. 300 miles of I-87 going all the way from Montreal to New York City. If you include the, was it 315 or I-15 up in Canada, that's an additional 50 miles. So 350 miles, New York City to Montreal. That didn't work. Oh, please. There it is. Okay. So the waterways, generally speaking, the North Country is surrounded by water. We have Lake Ontario, the St. Lawrence Seaway, all the way up the northern section of New York. There is Lake Champlain, Lake George, Hudson River. These are all sorts of different ways for people to access us or keep us separate from others, right? We are very much a bubble in Northern New York. We also have the Canadian border, right? We can't ignore the fact there's a whole other country right across the way from us. Generally speaking, from Plattsburgh, it takes about 45 minutes to go across the border. Okay, I-90 and services above. I know we have to wrap up. I'm going to get through this as quickly as possible. The reason that this is especially important is when we talk about the different aspects of delivery of care in the North Country, we are majorly cut off from a lot of different things. So I-90 is all the central area. North of I-90, there's 1.2 million people, okay? We are a level 3 trauma center. There is Canton Potsdam Hospital over here. Potsdam. This is us up here. This is us here. That is outside. And this is E-Town. So those are two critical access hospitals. This right here in the center, that's Adirondack Health, right? That is a standalone hospital. Canton Potsdam is connected with Rochester Regional, which is right there. That has a birthing center. Adirondack Health does, and so do we. None of us have high-risk pregnancy care. There are 0 pediatric acute care beds north of I-90. 0 in all of upstate New York. When you talk about behavioral health services, we have adult and child facilities. Adirondack Health has a geriatric center, so over 55. Ogdensburg has the state facilities. We deeply need care facilities in the North Country. We are lacking so many. And so when you think about the people that are most vulnerable, it is the ones that are not receiving the care, right? And this speaks to it. There's a lot about the North Country. Additionally, if you need gender affirming care, there is one physician at Hudson Headwaters for all of North Country. And by North Country, I mean everything. Oopsie daisy, sorry. north of I-90. Okay. Next slide. This was that beautiful big yellow area. These are the, this is the Adirondack Park. 6 million acres of land. Just over half of it is forever wild. And that is important because there is restricted access, restricted building and development laws, and restricted ability to get through it. 130,000 people live just in this area, okay? But within a 7-hour drive of this area is access to 84 million people. So we get a lot of people in this area. When we talk about the North Country again, here, it's above the blue line. The classic 5 counties are going to be in the top right: Essex, Clinton, Franklin, St. Lawrence, and Hamilton. That's 275,000 people. Okay, our state troop B, New York State Troop B, accesses those 5 counties, and there's one victim services person for that area. One person who's responsible for all of violent crime in all of that area. Below that, that blue line and above addresses people, the counties that are encompassed in what's called the North Country Human Trafficking Task Force. It is a group of people in the entire North Country and Quebec and Montreal and surrounding areas, trying to develop resources and connection for the work. Okay, New York State. So New York State as a whole in 2023 had 1,200 signals made to the National Human Trafficking Hotline. 400 came directly from survivors. 412 cases were identified, and 845 victims and survivors were assisted. We'll talk about our numbers. So we have started tracking our numbers since June. We know that numbers are important because they help us understand how can we help, what are the resources we can put towards people and services and systems. We've had 17 cases. That's 3 months ago. Of 17 cases, 11 were adult and 6 were minors. Okay. Of those 6 cases for minors, they all included what's called CSAM, which is child sexual abuse material. If you go to the National Human Trafficking Hotline website and you look for services, this is the map that comes up. What do you notice? Big, hot, blank area. They have nothing listed for the North Country. It doesn't mean that there are no resources, but it means that there are no resources that we have in the North Country that have connected with a national human trafficking response. So the importance of us logging these numbers and making sure they know, and also connecting with all of the different resources that we know are in the North Country so that they know to connect with the National Human Trafficking Hotline, because they're the people who are sending out the response. These are non-local resources, national and state. Each of these is a link. I'm going to go forward because I just want to show this. These are just a small smattering of the resources and partners in the area that I have begun to start connecting so that we can have people responding appropriately and at our fingertips for the breadth of care that's necessary for these cases. I'm trying to wrap it up here for you guys. Sorry, I know. So
I just wanted to say thank you to Em for, if you go backwards one. We weren't doing any of this before Em started doing it. I work mostly the clinical portion of it, and Em is building us a network of support. And I just wanted to say thank you for doing that.
Totally. We're in wrap up. Okay, so it's important to understand your legal requirements. You're going to want to know who's in your community, what are the missings and the possible areas to outreach to, who are your harm reduction partners. You need to construct a database of those resources and the key players. Multidisciplinary trauma-informed team, like we talked about. Policy and a tracking system, because the policy is going to tell you what you need to do. The tracking system is going to tell you for how many people, and then also give you access to more resources and funds. Educate yourselves in your workforce through all the different free ways. Outreach to those community resources that you built a list of to build those connections. Get some money. Money's going to be important for this. And take care of yourselves and your teams. This stuff is hard and it's painful and it's grueling and it requires a lot of time and energy. So build systems when you're doing this to take care of yourselves and your teams.
we don't have time for questions or thoughts. That was not planned. However, we want you to reach out if you're interested, and we want you to reach out to ask how to continue to build in your affiliates. What we want the most is to continue doing what we're doing in the New York region, but also what would be best for survivors because they move and they need to move is to have the Vermont spectrum and continuum available to us as well. So we need a network-wide approach, but for in the meantime, we're going to keep pushing forward and we want you to reach out if you have any thoughts or questions.
Thank you, Dr. Stewart, and Gail. We invite all of you to stick around because Dr. Stewart will be leading a call to action panel discussion to wrap up today's Health Equity Summit. Thank you. In the main room.
That's it. Yeah. All right. I was going so good. Let me look back at the picture. There we go.